Postoperatively, pretty much for all the procedures, the restrictions and activity levels are just about the same. Everybody is back to normal activity after these procedures, whether it's a minimally invasive, endometrial ablation, or a vaginal hysterectomy, or a mesh revision. Most of the restrictions have to do with comfort and just reducing postoperative discomfort and not having patients do too much. There's very little a patient can do to actually kind of alter the outcome of a surgery or to mess up a surgery, so to speak. But typically we tell patients normal activity for anywhere from, the restrictions can be as short as 2 weeks for an endometrial ablation, up to maybe 8 to 12 weeks for a more complex reconstruction or a mesh revision. And in that time, it's just normal activity, maybe no heavy lifting, more than 25 pounds during that time, and no excessive exercise, marathon running or powerlifting or things of that nature. In addition to that, the other restriction is really pelvic rest. So other than estrogen cream we may give to the patient, nothing else inside the vagina. No tampons, douching, or intercourse. But pretty much, even in the most complex situations, by 3 months out from surgery, they're ready to go back to their normal life. And that's at the high end.
What is the main difference between overactive bladder and urinary incontinence?
So urinary incontinence is kind of an umbrella term, and under that there are multiple types of incontinence. There's stress incontinence, leakage with cough and sneeze. There's urge incontinence, which is a part of overactive bladder, but also a part of urinary incontinence. That's leakage with the gotta go feeling. And there's other rarer types of incontinence called overflow and incontinence where the bladder doesn't function normally. Overactive bladder is an umbrella term for everything encompassing urinary urgency, which is when I have to go right then and there, to urinary frequency, which is I have to go many times during the day or night, to urge urinary incontinence. I have the urge to go and I can't hold it until I get to the bathroom. I start to go or I start to leak before I get there. So overactive bladder encompasses all of those urge-related and frequency and urgency-related symptoms, to include urge-related leak.
Can you talk about the treatment options for overactive bladder?
Overactive bladder traditionally is treated conservatively with behavioral therapy if the patient is drinking too much caffeine or too much fluid in general. In addition, we can add medications to that regimen. Some patients may need to have 2 medications to complete their to treat their regimen. Past that, if a patient really fails conservative therapy, one of the more recent options, probably in the last 10 to 15 years, is a treatment with sacral neuromodulation, which is a fancy term for using one of the nerves that comes out of the sacral bone that helps innervate the bladder, using that nerve to control the bladder. And that's done by using a little electrode that we place next to the nerve that stimulates the nerve and then basically tells the bladder what to do, almost like a pacemaker for the bladder, if you will. And that device is actually implanted under the skin on the buttocks and can be used for up to 5 to 7 years before the battery needs to be replaced. And the patient actually controls the strength of the impulse themselves, and they're taught to do that.